Thank you very much. Good afternoon. Anyone, if left over from pediatrics department, you presented very well. So a nice case for a CCR, and when we were students, it was a dictum: blame it on tuberculosis for not finding anything. It's a nice one. We will be presenting a case which is actually very common in the pediatric case group, but somehow we found it in an adult. And this patient had gone to all who's and who's of GI surgery or CTVS, most of the parts of India, and returned back to here in a very precarious condition. And she went through 4 surgeries, and it took 1 year to correct all the problem and make her stand again and come to the routine life. And it was so exhaustive that one point of time, actually, we were at a level where science meets spirituality. Um, this is about a patient. The case is to be presented mainly by the GI surgery people, but this is one case where Department of Anesthesia, Critical Care, CTVS, Surgery, psychiatric, all played their parts equally in equal amounts, I would say, in the extent. It's not that more or less. So it may appear that we are presenting what might be occupying not a major part of it. But we needed to present this case. Someone has to present out of all them, then we thought we would present. This is restoring life after recurrent needle injection induced crisis. The case would be started by our senior resident, Dr. Avinav, and then the stepwise, as he went through the management through different departments, they will be sharing their views. Avinav, please.
Good afternoon, everyone. So we have a 37-year-old lady presenting to our emergency with a recurrent hematomesis requiring multiple admissions, multiple blood transfusions over the past 2 months. So there was no history of any common causes related to this like ulcer disease, drug intake, or any liver disease or any malignancies. Though on repeated asking, she gave a history of ingestion of sewing needles over the last 2 years. So at that time, she was conscious. Her BP was on the lower side. So immediately resuscitation was started and NOD ADR was started. Her saturation was 95% on room air, which was about normal. There was no other significant findings in the examination. Her hemoglobin, though, was low, 6.4. We did an endoscopy and there was no source identified or any active bleed. X-ray revealed here, we can see a needle in the neck and the mediastinum. So with a provisional diagnosis of aortoesophageal fistula, a CTVS consult was taken. So I would like to call Dr. Navnita, ma'am, to take you further into the case.
Thank you, Abhinav. This patient was referred to us on 28th of October, actually 27th of October, and we planned, as the patient was bleeding so much, patient was like, she was throwing 500 ml to 1 liter of blood in one vomiting, and she had already 6 of HB. So we thought we should not wait to resuscitate, but we should plan a surgery. So, as the literature say, the aortoesophageal fistula has 40 to 70% of mortality if not treated, and if also treated, then it is 50% of the mortality. So, it was like giving your hand inside the lion's mouth. But what God can save, man cannot. Man also cannot kill. So we actually talked to the GI surgery people also, and we, in consensus with everybody, we took patient on next morning itself, and critical cardiac anesthetist, they intubated the patient with the normal intubation, but they put a bronchial blocker so that we can be able to work on the left thorax. And when we opened, there was a new thing I got. It was all adhered because she maybe after the injection she had some bleeding inside the chest, so everything was adhered. So we did an adhesiolysis. So this is the CT scan. First, I will tell you the CT scan. You can see the needle. I am pointing the needle. So we had a discussion with our cardio radio people also. So they said the needle is just going. It's not going inside, but it's just touching the aorta. So we thought, okay, maybe they are saying so, but because the patient was having bleeding, so maybe some branch has hit it or something like that, but we have to go inside. And here we can see the needle has actually two parts, which is not seen here. One was a longer part, and the other was a smaller part. The longer part was going from the esophagus towards the aorta, and the smaller part was actually going into the lungs. So then here we can see the needle. Okay, it has caused all fibrosis. And so I opened the chest. It was all adhered, and I had to do a decortication. This is the portion of the aorta, and you can see this is the fibrous part. I will show you a video. So this is the fibrous part which I am handling. You can see that. Okay, then we planned. Slides. Then we planned that we will clamp the aorta and just open the aorta and see what is there. So we opened the aorta. After opening, there is also a video, but it's not clear. I will just say it, that the needle was going from the esophagus, going inside the aorta, transversing it, and then coming out, and then going into the lungs. So we took out the needle, and then we did an anastomosis. We put a graft because the total length was like 4 to 5 cm, and we could not do it end to end. So we put a graft. Then the problem was putting a graft is not sufficient because there is an aortoesophageal fistula. So we closed the fistula with a pledgeted suture because we did a T, and there was just a small 1 of hole which was seen. Other than that, nothing was seen. So we just put a pledgeted suture, and then the part of GI surgery, they took a pericardial flap, pleural flap, and we took a homologous pericardium because the pleural flap was a little bit small. And then you can see the pericardial flap, pleural flap, which is being taken, and then it is being wrapped around the graft so that we will not have infection. But then also the patient on the 5th day had infection and means had discharge, and we did the culture of the discharge. It was E. coli, as must be from the gut. But we thought that maybe when we were closing the fistula, some amount of discharge had gone into the mediastinum, and that's why she is having that. So we gave her antibiotic for 3 weeks, and patient was okay. We did a secondary suturing, and we discharged the patient. This was the needle which we took out. So you can see there is only one part. The other part I could not actually go into search it, because it was inside the lungs. It was embedded inside the lungs. Post of course, their patient had paraplegia for some time, but now she is doing well, recovering from the paraplegia, and she was discharged on 23rd of December. Lower limb power was improved to 3 by 5. But the patient came back with fever and cough and a little bit of hemoptysis. So we decided to do a CT scan. You can see CT scan, and we found that there were some areas of gas inside the CT scan. So we thought that okay, maybe this is an infection. So we went for the PET scan, and we found that the PET was showing an uptake in the graft site. And there was septic embolization in spleen and left kidney also. Then we decided that we will go again and we will take out the graft and change the graft once again. But before that, because she is having an active infection, so we have to stabilize. So when we admitted the patient on February, but we gave antibiotic for 6 weeks and waited for some time for her nutrition to build and her HB to build. Then we took the patient on 10th of May to change the graft. And I changed the graft with, I had also taken advice of Dr. Mohit from um from surgery, and he came and we had discussion with our radiologist also. They said that this is because of the lung. The needle is still there in the lung, and the hemoptysis may be due to the lung. So we took out the we thinking that we will do a lobectomy. We went inside and we tried to take out the lung, but eventually we landed up doing a pneumonectomy, because the whole lung was adhered and it was not feasible to do just a lobectomy. But we changed the graft without any complication, and then we took out this needle. You can see this needle. So this was the other part of the needle, and this is the damaged lung. Post op surgery, again she had discharged from the thoracotomy wound. This time I was I was devastated, because second time surgery, doing a bypass, it's not so easy, because this tissue is not good, and you have so many questions. Does the patient will survive this surgery or not? But then patient's attendant had faith. I think if patients attendant have faith on us, patients has faith on us, then actually we can do more than what we think of. So I taking the all the challenges, we again went inside. Okay, in between I forgot to tell that in second surgery also we injected methylene blue, and I had asked Das sir. He told we can inject methylene blue, we can do an endoscopy, and we can see. So that all we did, but there was no leak. So we thought, okay, this must be just the infection which had been before, and due to lung it has increased. So then, leaving all that, I went again for the surgery, and uh, this time it was, yes, it was esophageal leak. We had already suspected. This is the X-ray of the patient before surgery, and this is the wound you can see on the left side. Sorry, on right side. And we did a barium swallow. In barium swallow also, we found nothing. We just found a protrusion, but there was no leak. But then we had decided that this time also we'll change the graft. And in CT, we found some fluid with air foci and subcutaneous emphysema. So we went again, we did a graft change a second time, and this time Dasar was prepared to do a momentum flap of the graft. So I call Abhinav to take over from here.
Thank you, ma'am. So, with the diagnosis of perforated esophagus, infections in the chest, and the risk of reinfection of the graft, we gave introp assistance. At that time, options were in the literature to either primarily repair the leaking esophagus, do a endoscopic stenting, or divert the esophagus, or do any immediate resection and reconstruction. So we opted for diversion because it it gives us the best chance to control the infection, control the sepsis, provides FJ for feeding, and is a soft and short and safer surgery. So as we can see, this is the changed graft done third time. Here is the cut end of the esophagus. We have divided the mid-thoracic esophagus. This part of the esophagus was left because it was densely adhered to the remnant aorta. The omentum was prepared and it was wrapped around the graft. The neck incisions were given and the cervical esophagus was brought out and matured as the stoma. Feeding jejunostomy was done for the enteral nutrition. And this is the final surgery completed picture. This is the closure of the thoracotomy wound. So after the third surgery, patient improved steadily. We were able to establish the feeding from post-op day 3. And with the plan for restoration after 3 months, we discharged, she was discharged from the CTVS actually on 6th of July. That was 2 months after the surgery. She continued to follow up in our OPD. Her nutritional status, exercises, pulmonary and neurological status were monitored. Psychological counseling was done. The aim was to optimize her for definitive surgery, which was planned after 3 months. But the challenges were she was not tolerating the feed well. There was indigestion, bloating. She was severely malnourished. Because of the single lung physiology, her and poor chest condition, residual limb paresis. The plan was then to take the calculated risk of restoration against all these adversities. So we admitted the patient with us in January 2026 in severely malnourished status. She was having pallor, she was dehydrated, and her surgical site were healthy. At that time, her hemoglobin was 7.2, her albumin was low. This is the chest X-ray. Here we can see the right lung hyperinflated and residual needles in the neck and mediastinum. We did a CT. CT here shows a residual esophagocele. This is in the connection with the mediastinum fluid. This collection was intentionally kept so that it could prevent the shifting of the right mediastinum to the left. So we rehabilitated the patient, started her on parenteral nutrition, corrected anemia, albumin was supplemented, and with physiotherapy. Now on 13th of January, we taken up for definitive surgery. So we proceeded with the midline incision. This is the surgical abdomen. Here we can see the dense adhesions. This is the stomach. This is adequate and this is soft and pliable for the reconstruction. So hiatus was opened. Here we can see the mucoid discharge coming out from the hiatus, the esophagocele. This was drained externally. And the stomach was being mobilized on the 2 vessels, which would provide the blood supply for the conduit. Here we can see the gastric conduit. And through below the sternal root, this we call it the retrosternal root, we pulled the stomach to the neck. And finally, the esophago and gastric anastomosis was done in the neck. Here, this is the stomach and the esophagus and anastomosis. And this is the final picture of the closed neck. So, patient in the post-op course, we were able to give her orally on post-op day 5. She accepted oral liquids well, and patient was discharged. She was stabilized and discharged on post-op day 17. So now this patient who had come to us in October 2024, she has underwent aortic interposition graft, which was complicated by infection. Pneumonectomy was done and graft replacement. Then cervical esophagostomy, that is the diversion, and finally the retrosternal gastric pull-up was done. So to take you further into the case in the lights of evidence, I would like to call Dr. Hari JP for this one.
Good evening. Continuing with the discussion. Aortoesophageal fistula are rare, often catastrophic. It entails a direct pathological connection between the thoracic aorta and the esophagus. It may be primary when aorta has not been handled surgically, with like in diseases of aorta like aneurysm, foreign body ingestion, or any esophageal malignancy which is advanced, or secondary, wherein which is increasingly encountered in the era of aortic graft repair or endovascular repair. The first case was reported in 1818 by a French naval surgeon, and clinically characterized by Chiari in 1914, wherein he described aortoesophageal syndrome. Its clinical progression from pain to sentinel bleed and exsanguination, which remains relevant even today. Without intervention, mortality approaches almost 100%. Now, it occurs, the accidental ingestion of foreign body as in case. This occurs most frequently in vulnerable populations such as young children, the elderly with dental issues, and individuals with intellectual difficulties or psychiatric illnesses. Needle ingestion often are rare. However, they are thin and sharp and can migrate or tend the aortic wall. Why it is commonest? Where it is commonest is around 1 to 5 centimeters from the subclavian artery origin, as you can see. Why? Because this area has got a relative narrow esophagus, and it is closely approximated to the esophagus. Needle-induced aortoesophageal fistula remains exceedingly rare, as I've already told, with only isolated case reports reported so far. Management strategies range from endovascular repair, open repair, conservative management, or a staged resection. Outcomes, however, has been inconsistent. Across reports, one consistent observation is that hemorrhage control alone is not sufficient. Durable survival requires definitive control of the esophagus with source prevention and prevention of graft contamination. Now, these foreign bodies in the esophagus can migrate into bronchial structures, which makes it even more complex as in our case. However, once vascular erosion occurs, the clinical trajectory completely changes. Vascular involvement transforms a contained problem into a surgical emergency. Our case had unique and sequential challenges. Firstly, during the first intervention, the endoscopy failed to demonstrate any active fistula. Subsequently, the graft infection and lung damage complicated the clinical course. By the third stage, patient was physiologically fragile, sarcopenia, nutritionally depleted despite best efforts, with paraparesis and single lung pathology, placing her at a huge risk for anastomotic leakage. This was not merely a technical challenge, but it was a physiological challenge as well. Now, in the setting of primary aortoesophageal fistula, like in this case due to needle ingestion, definitive aortic repair is mandatory because otherwise it stays inside, creating more problems. An orbital wrap was employed in this case to reduce graft infection. Given the patient's compromised physiology, we adopted a staged approach. Cervical esophagostomy first, we created an opening in the neck to divert the esophagus, limited resection of the deceased esophagus, and delayed retrosternal gastric conduit reconstruction for preservation of the GI continuity. Each step prioritized sepsis control and physiological optimization over any procedural expediency. Now, this table summarizes the various variations in surgical therapy. Contemporary reviews suggest that there is no significant survival difference between simultaneous and staged esophagectomies. Endovascular repair, namely TEVR, serves effectively as long as a damage control modality to control hemorrhage. However, it does not prevent ongoing sepsis. Thus, definitive management ultimately should address both pathologies. Data consistently demonstrate marked improval of survival if you do surgical therapy rather than wait and watch, as you can see in this. So, non-operative management in aortoesophageal fistula carries extremely poor prognosis. Intervention is not optional; it is imperative. Now, patients undergoing graft replacement after significant graft replacement show significantly better outcomes. These are patients, survival of patients who underwent graft replacement alone. They show significantly better outcomes compared to patients who have undergone other modalities, TEVAR, or taking out, doing a stent of the esophagus. This underscores the fact that persistent graft infection is a major driver of late mortality. Similarly, removal of esophagectomy confers a survival advantage compared to stenting or endoscopic closures. Persistent esophageal defects perpetuate mediastinal contamination and compromise graft integrity. The most favorable outcomes, as you can see in this, are reported when both the aorta and the esophageal pathologies are addressed definitively. Dual source control, vascular as well as enteric, appears central to survival. Now, management algorithm can be grossly divided into 3 phases. Immediate phase, which is in the first 24 hours, the priorities are very clear. Resuscitate, protect the airway, rapid imaging like CT angio for diagnosis, and broad spectrum of antibiotics, of course. At this stage, the objective only is stabilization. Hemorrhage control follows immediately after this phase. In contemporary practice, this is achieved by TEVAR. TEVAR is basically endovascular stenting, and it functions as damage control. It stabilizes the patient, buys time for the surgeons. At the same time, broad spectrum antibiotics, of course. Endovascular control is not a definitive treatment as it controls bleed and not the source. The intermediate phase is about survival. The definitive cure requires what follows next. Once the immediate threat of exsanguination is taken care of, the focus shifts from damage control to definitive source control plus durable reconstruction. The first priority is esophageal source control. It can be either with diversion or esophagectomy. Depending on physiological status and degree of mediastinal contamination, this may involve diversion, as I told you. Secondly, the mediastinal debridement and drainage. There is some amount of infection already lurking in the mediastinum, as persistent mediastinitis is one of the major determinant of mortality. Thirdly, an aortic infection control strategy, which is individualized as infection persists, and graft explantation with reconstruction may be necessary in such cases. So in effect, a needle, a small object, created one of the most lethal surgical catastrophes we can consider. Aortoesophageal fistulas does not forgive delay. Control the bleed, control the sepsis, reconstruct only when physiology allows. This case demonstrates that even in the most hostile circumstances, like an infected graft, lung damage, frail physiology, a thoughtful stage strategy can bring patient back from the brink. In aortoesophageal fistula, survival belongs to a prepared team. Thank you. Now I invite Professor Das to elaborate further.
Nothing to elaborate more. Sorry, we took another 3-4 minutes. This is the last slide. Sometimes people start experimenting with their life, and then still they get away with that. And we had the opportunity, or we are unfortunate enough from the patient point of view, to manage 2 such cases. One is this one. The only one was all over the place in media, wherein we removed a 20-centimeter knife that had gone through the ampulla into the liver, and we had to remove that one. So ultimately, it is decided in the upstairs. So thank you very much, and I wish all of you we're blessed by God. We have acknowledgement. I have acknowledged a lot of all the departments. Sorry, the 4 slides from surgery. because one of the major part of it was to take out one lungs. It's not a matter of joke. So Mohit is there. If you allow, he'll present just 2 minutes about how he took what was the need and he took out the lungs. And then finally, I will wish you a happy Holi from one point of view. Just.
So this is just to show you that how we do left pneumonectomy. Like we already got the patient the table. It was kind of a referral we received for a possible pneumonectomy in this patient. The only debate was whether we can save the lung or not. We decided not to save the lung because the lung was having low volume. It was quite destroyed, and while mobilization there were lacerations. Even if we would have saved that, that would have led to a long air leak period. During that prolonged air leak period comes like infections and the other things. And we don't infected hemothorax in this patient. So this is how we post the patient for a possible lung intervention. So patient lies on the lateral side. We give a posterolateral incision. Actually, this is not the same patient, it's a different patient, but just to show that how the patient is on the table from the front and from the back. And we fix the patient, we break the table so as to widen the spaces between the intercostal spaces. We count the space, the surgeon usually stands on the posterior side. And this is how we kind of mobilize the lung. So here is the aorta. And then we start mobilizing from the pulmonary artery. This is how the pulmonary artery it looks. We loop the pulmonary artery, then we go for the pulmonary vein. So this is a superior pulmonary vein. We mobilize it from below, and this is the inferior pulmonary vein. And we tie them sequentially. So the usual sequence would be that we tie the pulmonary artery first, then the pulmonary veins, and lastly the bronchus like this. So once all these things are divided, the pneumonectomy is done. Thank you so much.
So any opinion from anyone or any questions, please?
Three times, not once, but three times, and to conduct such a massive operation and guide the patient out of the post-operative course. Congratulations, madam. Congratulations, sir, and others of the team.
Thank you. One thing, just one line I need to mention, because Dr. Nandakumar was to be here. He got busy in one of the meetings. See, this all throughout this 1 year, only one thing that made the patient possible to undergo surgery time and again after this thing, she was barely able to sit, was the psychological counseling. Every step that yes, you have to go through this period for a year or so, maybe 1.5 years. So counseling of the patient, counseling of the attendants, the husband and others and children was so important, which that part he handled so nicely. So that's what I wanted to mention at last. Thank you very much for being here. Thank you.
Team actually matters, and I would thank my anesthetist. Dr. Arindam is there for the 3 surgery. One Dr. Sambhu and Dr. Surichi and Arindam sir. So 3 of them were there, and they all supported me, and obviously my residents and Das sir and obviously Mohit sir. They all supported me, and yes, whenever I called them at night, also Das sir listened to what my queries were, and obviously Mohit sir also helped me. So I will say that team matters.